All righty, so I think this is meeting number 4, maybe for our group. I can't quite remember, but thank you all for sticking in there. Today, we are going to hear from Cindy from Amita St. Francis about the crisis line. And then Chief Scott, the fire chief, is going to talk about the program that he, I guess I would say, leads over at St. Francis as well. I know it's being revamped, but this is part of our kind of learning and assessment of what is currently available in the city of Evanston as we continue to work through and work towards developing an alternative response pilot program or response program. We're not sure exactly what we're going to call it. As you might have realized, we're going through the budget process now at the city. I know it's never a great budget year. This one is following suit with others. But I am trying to squeeze every penny I can for this program. One, to not be a tax item, which it is right now, but then two, to just be as the budget to be as full as possible, because as we learn and understand the needs, I think we all will agree that we rather have more services than we need available. I don't know if that's even possible, but we don't want to start something that is not going to meet the needs as best as we can. So right now it's allocated for $200,000. I have no idea what that means in terms of salaries. I guess in my mind I've been thinking 3 people, but I have no clue. So we're going to continue to try to find whatever money we can. Alderman Ravel and I turning over pillows and picking up pennies to get more money here. And thank you all for coming. I know that we had, unfortunately, another loss of life. This has just been the worst year in America. Well, not the worst, but a bad year for Evanston. And I know Evangeline has been doing a great job reaching out to, unfortunately, mothers who have now joined and losing children. And so I just want to recognize and appreciate you for what you're doing there. We have no idea what that's like. So thank you for filling in for that gap in our city. And then also I will share a link, but also due to Evangeline, that I have been introduced to a shared safety kind of framework for violence reduction and safety, community safety. Alderman Ravel and I had them at Human Services a couple months ago, I guess. I will be hosting them in the 9th Ward, and I say them meaning the director of this program, in the 9th Ward for community conversation about what does safety look like for everybody. So I will share the link if you are interested in participating. It's actually a 2-part conversation, and it's not something that they are going to, sell to us. It's not a consultant who's going to come in and like sell us on this framework. It's really just nationally kind of working through what does safety look like. And it's really, and eventually can speak more eloquently than I can, but it really started with thinking of survivors of victims and having them kind of participate in what safety looks like. So I think we make a lot of decisions thinking, as we're doing our best here, thinking, what does someone need? And we're not necessarily the someone. So trying to be really mindful about thinking through these things, which brings me to my last point, which is I have been trying to reach out to some folks who I know from my time at Connections, who are still somewhat in the homeless space, to have them come and speak to us about what their experience with police is. But also wanted to invite you all as service providers, if you have, clients, or preferably clients, not just, staff, who might be willing to come and just share with us a few minutes of their thoughts in terms of what they think is beneficial for this response model, whether it's the kind of skills that the staff needs, what kind of resources staff needs to be able to offer people. I think that's kind of the one thing we don't have on our list to try to tackle. And I think that that's very valuable if we want to make something that serves people, that we actually try to speak to people we're serving to see what they need, and we're not just doing our best guess at it. So we'll add that onto the kind of last scheduled meeting, which will be in, I think, the 2nd week of December. Will take us through kind of all of the topics we wanted to discuss, and then we can kind of revisit and see what our next steps are after all that's done. So I'll share the link as the meeting goes on and I find it. But I want to turn it over to Cindy. Cindy, if you want to just introduce yourself. And this is I think you participate. It's a very free flow, and you tell us whatever. We kind of go back and forth with our questions, and we don't really have, list of questions for you to answer.
Yes, no, thank you for having us. So I'm Cindy Castro. I'm the manager for the Outpatient Behavioral Health Clinic here at St. Francis. And I have a couple of people on here, and I'll actually let Danielle take over this part of it. So we're going to give you guys a PowerPoint just to give you guys visuals. So I know Danielle and Chief Scott will presenting the first part of it, and then I'm going to jump in to talk specifically about the behavioral health component of it. And then we also have Erica Green, as I mentioned earlier. She's an ER crisis worker, but also covers the crisis line. So that's just in case towards the end, we talk a little bit more in detail, and she'll be able to provide her insight to that. So Danielle, if you want me to share the PowerPoint, and do you have it on your end?
Yeah, if you can share it, that would be good. So hello, everyone. Thank you for inviting me. I am Danielle Norman, Director of Emergency Services and Critical Care at Amita Health St. Francis Hospital. I have also been leading the ECHO program that we have with the City of Evanston's Fire Department for about 2 years now. So, oh, perfect. There is the presentation. And I know that Chief Scott, I believe I saw you on, right?
That's correct. Hi,
Okay.
Danielle.
Hi. Okay, so we'll go ahead and get started. So Amita Health St. Francis Hospital partnered with the City of Evanston, the Evanston Fire Department back in, it was 2017 when we began these conversations, maybe even further back than that. Cindy, if you can go to the next slide. So in 2019, we started the partnership. We named our program the Evanston Community Health Outreach, which is ECHO, as a part of a mobile integrated health community paramedicine program. A mobile integrated health approach provides at-risk individuals with free in-home medical visits, health education, social service referrals, and home safety inspections. So we have a nurse navigator that is here at Amita Health St. Francis Hospital that works closely with a community paramedic through the City of Evanston. And that nurse navigator will screen at-risk patients, provides the ECHO program introduction as well as education. What we focus on is our at-risk population. So we're looking for our congestive heart failure, diabetes, pneumonia, COPD, and a few other areas. And we want to get those patients enrolled in this program. Once enrolled, the client will receive 4 home visits from the community paramedic as well as the nurse within 48 hours of discharge. And the goals of our program ultimately is to reduce non-emergent 911 calls. We want to reduce non-emergent emergency department visits, reduce inpatient hospital readmissions, and to help patients navigate this complex healthcare system. We want to educate patients on how to establish and maintain care with their primary care provider, as well as identify health disparities and provide community connections for our residents, as well as improve patient outcomes. So since launching this program back in 2019, when we launched it, what we found was that we had a small outreach. This program was really geared towards Evanston residents that had chronic medical conditions. And we just have a small reach of Evanston residents that are utilizing St. Francis Hospital for their chronic conditions. So it was very difficult to recruit patients for this program. Most of our patients that did volunteer to enroll in this program really did not need the full services that the ECHO program could offer, such as the safety inspections, the referrals to community organizations. Those patients were pretty self-sufficient, so they didn't really benefit much from what we could offer with the ECHO. And those who could benefit from the service just really would not engage. And we tried different tactics and different models to try to help capture patients while in the hospital and outside the hospital to enroll them in our program. Because we have multiple hospital systems located within the North Shore region, we really also tried to work with North Shore to also see how we can maybe come together as one to have this one program for Evanston. And then ultimately, a lot of patients really were just resistant to having strangers in their home. So that was another challenge for us. So here's some data on how we did from 2019 when we launched the program. We did put the program on hold due to COVID. So this data actually is not a full complete year. So the ECHO program introduced 46 patients to this program, 14 patients enrolled, 9 patients of the 14 participated in the home visits, and 32 patients declined. And what you'll see here is how many of those patients had CHF, COPD, pneumonia. It gives a breakdown on where our greatest need was with patients with chronic medical conditions. And maybe, yeah.
Can I ask a question before just so I don't forget? Were these these were not the only chronic diseases you were willing to treat? Are these just the ones you pulled out? Or are these only the ones you targeted?
Yeah, so we targeted six areas. It was our congestive heart failure, COPD, pneumonia, diabetes, a post-heart attack, and patients that had orthopedic injuries, like if they had frequent falls, maybe a most recent knee replacement that was coming to our ER. That's kind of who we focused on for this program. And I think because we limited ourselves to only those patients that were Evanston residents that had those chronic conditions, we did not see the volume that we were hoping to see with this program. And maybe Chief Scott, if you wanted to chime in.
About what specifically, Danielle?
Oh, just the program, the volume, and just, yeah.
So we did calibrate some of the types of patients we were seeing, again, to kind of expand the outreach, but we did want to target those medical patients that we were seeing the highest degree of readmission to. So we were trying to focus on chronic conditions that were low acuity, that we thought we could best manage and provide better care in the field versus those folks in that population that would keep on getting readmitted to the ED, and which really increases the cost of their medical care and really doesn't provide the best medical care at that particular time for them.
Mm-hmm.
So you got to remember, like, the reason, the genesis of mobile integrated healthcare is from the fire department, paramedic side of things. We have pretty expansive training and equipment, but for these low acuity chronic types of conditions, we have two choices. We can take them to the ER, or we have to refuse care, or they can refuse care and we leave them at home. And we know that there's other better options in between those two choices. And this is where mobile integrated healthcare, or the ECHO program, can fill that gap, which just also includes behavioral health and substance abuse. And so where we're seeing, I think, this lack of outreach is because of that recruitment piece that Danielle referred to before. We're getting them after they're in the ER, and we have that, that good dialogue with them, and we try to recruit them into the program, which is free. And we feel, I think, to expand the program and make it more effective, I think we're going to have to add a 911 kind of triage component where our 911 dispatchers could be trained to send out the ECHO program team right at the point of the call for service and reach them right at that particular point, and then give them the exact care they may need, and even transport them to someplace other than the emergency room. For example, urgent care, or a mental health facility, or substance abuse facility, to get them the exact care that they're looking for at that time.
So this is just a recap of what the ECHO program was, ultimately to provide whole care, that whole person care, that consisted of follow-ups, home visits to avoid ED revisits as well as readmissions. And ECHO was really kind of considered an aftercare option. After your hospital admission, after your ED visit, is when you would be introduced to this program. and how we were introducing them was during their hospital stay.
So we look at the next phase of this to be where we could do something where we have advanced provider responding units, where we could put up an actual ambulance dedicated to mobile integrated healthcare that would have a paramedic and maybe a nurse practitioner or even a physician's assistant. Both these individuals trained in behavioral health, trained in substance abuse, along with their regular medical specialties. And not only could they handle some of these behavioral issues that we might see in the community, but they could do everything else that a paramedic and PA could do in the field. So it would be a more expensive model, I would have to say, to be honest, especially if we ran it 24 hours a day. But the amount of value we get out of it, I think, would be exponentially higher because of the abilities they could have to do telemedicine, for example. They could do ultrasounds in the field. They could prescribe medicines in the field. They could do all those kind of address chronic, non-emergent types of medical care instead of bringing in a fire truck, an ambulance, ALS trained paramedics, and then having to direct them into the emergency department and going down that track.
So what we have, right, so you guys have been hearing kind of that ECHO program on the medical side of it, right, in terms of this chronic medical conditions that they're targeting and stuff like that. So what we also have is our behavioral health community support. So this is what we have through the city of Evanston that you guys have probably heard a lot about in terms of the presence connection, right? So now we're AMITA. So what we have with the city of Evanston is, you know, it consists, so the contract that we have has 3 separate things on it, right? So we have our full-time licensed clinical social worker that's stationed at Evanston Public Library. Then we have our community support program, and this is where it kind of models the ECHO program on the medical end in terms of being able to provide home visits to Evanston residents for what we call those frequent flyers, right? So we're calling them readmissions, but it's really those frequent flyers are in and out of the ER and are not tied to any other agency. So the way this program was working initially was that we would get the direct police reports from the Victims Advocate Department that we just heard, this group heard about last week. So we would get those reports and then we would follow up with a call or a visit, whatever the need was at that point. The program then started switching a bit because then it was like, okay, we're a partnership with the city, but what was happening was that we were reaching out to all these individuals, but they were not aware of who we were and why we were calling, right? So that presented an issue. So then we went back with Victims Advocate on what they can do a little bit more in terms of a release of information, making sure we have consent for them to be a part of this program. So we've been working on that kind of for a long time. So right now, the way it stands is that most of the referrals that come through the community support program are from city staff, from the Evanston Public Library, if it's somebody that needs ongoing support or maybe more support in the community than what she's able to do at the library itself. Then we do a lot of, you know, from our crisis worker, from the city staff. When I say city staff, I mean like the youth and young adults program has done a lot of consulting. Like if they're interacting with somebody and they just kind of need to know, what do I do next? Can you assist them or whatnot? So then I might do some consulting work with them. I also get some people from like the general assistance office, from their workers, that they're working with somebody that needs a little bit more support. Pre-COVID, of course, I would go into the general assistance office and be able to meet them there and get that introduction and kind of get that relationship going. Now it's been more of just consulting via email, and then sometimes they'll just send me the individual just to kind of, so that way the individual can ask what are their needs, and I assess a little bit more. So I really serve as like a triage to whatever it is that they need. And then we have our 24-hour crisis line, right? So this is the crisis line that's available 24 hours to any Evanston residents. The issue with the crisis line is that Evanston residents can use it, but they might not identify themselves as Evanston residents. So then it's hard to track the number of Evanston residents calling our crisis line because they might not disclose that information. And the feedback that we've gotten from the crisis line is that people enjoy being anonymous sometimes, right? Especially around mental health and the stigma and stuff like that. So they don't want to say that, you know, any information that might identify it, they don't want to say it. So sometimes we'll get that information, but sometimes we don't. So that's just to reflect, once I talk about the stats, so you guys are kind of aware why those numbers are where they're at is because we're probably not capturing some of the Evanston residents. Not just that, but we also have the 24-hour crisis line also has a contract with like Turning Point, for example. Turning Point's in Skokie, but the residents might live here. So they might call and identify themselves as Turning Point clients. So then we might track it that way versus tracking it as an Evanston resident. I think with our community support program, also if I talk a little bit more about that in terms of what we've done. So we've had that contract since 2013. And we've been able to fill the library ever since then. At first we were filling it with just student interns, and then we ended up in 2017 hiring the full-time social worker. But what the contract allows us to is kind of that aftercare piece, right? So the pattern that you're here is that we're kind of that aftercare. So after the police respond or after whatever happens, we're kind of that link to be able to build a relationship and connect them to services. But what that contract has allowed is that we're able to provide services without asking, what insurance do you have? Do they have to become an official client of ours? So for example, on my caseload, and my caseload is very small because I'm manager, but I know I have currently 2 clients that I see through the program. And what that means is that, yes, they have insurance. So for example, one of them has insurance, but they only have Medicare. They don't have a secondary insurance. So what that means is that Medicare only covers 80% of their services. So the other 20%, the person would have to pay out of pocket. But through this program, we don't charge them for that 20%, and I'm able to continue on providing that service without charging that piece of it. And I've been seeing this client for 5 years already under this contract. I can tell you that if this wasn't a part of it, he would struggle with it. And he was also one that would call 911 all the time. So instead of that, now we've kind of guided him to say, okay, now I'm established working with him, and then now he'll call our crisis line instead of calling our 911 and stuff like that.
Cindy, can I ask a quick question for that? So
Sure,
you said
go
you've been
ahead.
working with him for 5 years. So when you say working with him, is he like receiving
Therapy.
therapy services? So he's
Yep.
like a weekly standing appointment where he is having therapy appointment. Okay.
He's an official client and I'm his therapist. So yes, he's receiving ongoing services with us.
All right. And so about how many Evanston residents are you all seeing through the program in that capacity? Not just
So
like
that capacity for the continued work we do mostly, that's kind of like a one-off, because most of them are like, right now we have probably about 5 that are identified clients already with us, as opposed to we have some at the library that are ongoing with the social worker at the library, but we don't count them as official clients because the library does separate, like we don't even do any type of billing. So they're never actually an official client of our clinic. So that would just go where it's literally regular patrons that the library social worker will do regular check-ins every week. So it's kind of like an unofficial counseling over at the library.
okay, but so the majority of the clients you see or who come through this program or crisis line, they're not receiving ongoing therapy.
No, because then we assess them and then we might connect them, right? So that's when we have partnership with Trilogy or whatnot. So we might connect them to that through thresholds because they might need more intensive services. Or some we've had in the past, but they've been with us and then we discharge them in a way after like a year or so. So I had somebody that I was working with that, we were able to guide them through their process, able to get them a job. And then they were no longer in this type of program. And then here and there, I might still get a call after a year of not seeing them, just kind of as a check-in and just to let me know how they're doing, but it's not an they're not a part of my caseload at this point.
Okay, thank you.
And also with this community support, so we've been able to do a couple of just community stuff. So we do also training. So we've done trainings with like the general assistants, like they're pre-COVID, right? With all of their applicants. We've also been able to do crisis intervention trainings to the staff over there. Currently, actually, through this program, I'm actually going to start a Spanish-speaking women's support group that's starting this Thursday. And once again, I'm able to offer that because, right, free of charge, no diagnosis attached to it, not, just because we do have this partnership where I'm able to provide that type of support to the community. So then you'll see the data a little bit here. So 2020, so this is through September 30th, right? As we count the third quarter. So these are the reports so far we've had 464 encounters at the library / community support. So that's a combination of what my workers doing at the library plus the community support that we've done. Well, when we say encounters, these are face-to-face interaction or COVID remote, right? So encounter means any interaction. This might also be 465, might be a duplication. It might be one person that we've seen 10 times at the library. And then you have 64 identified Evanston callers to the crisis line. So once again, as I mentioned earlier, where this means that these are people that actually identify themselves. Because if you then count just all the calls that we get, in the first 2 quarters, we got about 900 and something calls to the crisis line. But out of those, only 64 identified. So then you have the comparison of the 2019. So at 2019, we had our overall numbers for the entire year were 732 encounters. Combination again of library and the community support, and then 228 identified Evanston callers to our crisis line. So then, like I said, this is just right to give you guys an idea of what we do in terms of the aftercare part of it, right? And I think what you guys are trying to look at is filling that gap of that 911 call initially, what happens, you know, when somebody calls, you know, who reaches out to that. So we would kind of serve as like that aftercare. What we're also doing now, so this is the other piece that's already been happening in the ER, but we're just kind of expanding it a little bit more. So we have in the ER, in St. Francis ER, we actually have Trilogy and Peer Services providing programming there. So we call it, right, the First Steps to Recovery program. So between Peer Services and Trilogy, they offer a couple of hours, you know, in order to cover most of the day at the ER. And then they'll be there to work with our crisis worker and the ED team to identify those that are in the ER that need either mental health or substance abuse services. So they're able to meet them at bedside. And hopefully out of that, right, is that, you know, they walk away with the referral already connected to their services. So I know you guys have Maureen. I actually asked her to talk a little bit more about this program just to give you guys an idea of what that program looks like. But just, you know, seeing the coverage we're kind of, because we see the need in the ER. So then we've brought in partners to be able to fulfill that need. So Maureen, if you want to briefly maybe touch on this program.
Sure. So just switching roles for a second to fill in some information. So Cindy, thank you for describing this all so well. We were very pleased to be able to do a pilot project last year with funds from the Evanston Community Foundation that gave the hospital and us an opportunity to see, you know, could we really add value if we did it this way, and could we help? And I think we all became convinced that we could be that this kind of an approach could be part of the solution of, you know, because what can often happen inside the hospital is people get really good care, they get patched up, they get information, but they don't get support for really making a plan to start a different kind of care when they leave. And so that's really the goal of this project, is to, for both us and Trilogy working together to cover some more of the behavioral health service need on the way out. Just to be clear, both of our organizations will be making referrals to lots of places, not just to ourselves. So lots of people will, you know, when they leave the hospital, if they've been very severely intoxicated for a long period of time, for example, they may need to go to a residential facility for a short period in order to get stable. And then, you know, kind of see what happens from there. But the goal is to help people understand what their choices are and help them make a better choice than just going out and repeating what they had been doing before, especially in terms of alcohol and drug use. And we will follow up with people for 30 days after their stay in the hospital by telephone. We don't have the capacity to do the home visits like the ECHO program, but we have recently been starting to talk on the AMITA team, including with Cindy, about how we might integrate with ECHO for Evanston residents, just to, you know, make those additional connections.
Thank you, Maureen, for switching gears so quickly.
Can I have you, as you wrap this up, I'm going to have you stop sharing your screen so the whole group can engage.
And we're done. Yep.
Oh, perfect. Okay.
Right on
Is it
time.
possible that you can email that to myself or Indira or somebody so we can get it to the group afterwards?
For sure.
Okay, perfect. All right, committee. So that was a lot of information. We might have to go back to the slides, but I wanted to make sure we had time to ask questions. I can get us started. I have a slew of them. Okay, so for the community support piece, so you have the capacity to offer long-term therapy or get people to some long-term supports, whatever they qualify for. Okay. And so for the crisis line, because I think not until a couple years ago did I even know we had a crisis line. So how is that advertised? And part of that I'm sure is on the city, but how do people know that we have a crisis line to call it?
So our crisis line gets promoted in different ways, right? When we started the program, we actually went to the police station and gave them a lot of boxes with our crisis line, so that way they can carry with them and be able to just kind of pass those out. Here and there, we, like with the partners that we had within the city, I would go and fill up their flyers, so they would have flyers of our crisis line plus our community support, so they'll have that in their offices to be able to share that. We promote it, of course, at the library because that's where we're at as well. Right now, it's being shared through the Emergenc Care Network, so we're on that partnership there and being able to promote it that way. Also, with being a part of the mental health task force for the city of Evanston, we're developing educational materials, and that's the number that we're giving for that 24-hour support, along with the 311 number for additional resources for them to help navigate with Evanston Care Network. So I think it's in different areas that it's being. It's also been on the city website, but I do agree that it wasn't promoted as much as it should be.
Okay, and then if folks call, and I know you and I had this conversation, but if people call the crisis line, what is the follow-up, right? So they might call having one moment, one night, and then might not call back again, but what is the follow-up that your team does with them?
So originally, right, well, we have our crisis line doing that. I'll have Erica maybe fill in what I might not be able to cover. So with this program, it's also, right, I think you guys heard it last week where it was like, people have to be willing to get these services, right? So when they would call the crisis line and they would deal with whatever situation and they would assess and be whatever the resource, they would get offered this program to be like, do you want somebody to follow up, to give you a little bit more information, to reach out to you at the home or anything like that? So it was really up to them to say yes. If they said yes, then the crisis line workers would gather their information, send it over to my team, and then we would reach out to that individual to try to make that connection. So it's really just voluntary, right? They would have to be willing to do that piece of it. So here and there, I still get some where it's where they do want that follow-up, and the follow-up might just be very brief. The follow-up might just be because they wanted to talk more and get more specific resources, or to help, it'll be us helping them link to a certain provider and stuff like that. Eric, I'm not sure if maybe there was more that in terms of the crisis line.
No, I mean, you got most of it. I would say that for some contracted agencies, if someone calls in, if we know that we are from a specific center, we will contact the agency next day just to let them know that a particular client called, they had some concerns, and so that the regular therapist can follow up.
Okay, and then my last question is about the piece with victims advocates. So you mentioned that in the beginning, you were getting the police reports, and then that kind of didn't pan out. So I guess between you and Indira Perkins, who manages our advocates, or DC Barnes, I'd like to hear more about why that's not working, how we can get that to work. I mean, I think that's a big piece of, folks who maybe don't need police, don't need an alternative response to their, home or wherever they might be, but, have had an encounter with our police, which, they still need some support from, not from the police part, but from whatever happened to bring the police. And our victim advocates, as we know, they respond to lots of things, but not everything. Right. And so it seems like there would be a huge gap of people who need some support who aren't having any follow up. So that would be huge if we can get that piece repaired. So,
yes, we've been talking a lot about that.
Yeah, so I'm sure there's a confidentiality piece there, but we should be able to work through that. So Indira or Barnes or Cindy, can you help us figure out where that is now? Does it just not exist? Did it ever exist?
So there were a number of legalities that needed to be worked out with releasing police reports to an outside entity, from my understanding.
Yep.
So that's what put a stop to all of it.
Okay, and is that, Indira, not because they were coming from the police to your department to Cindy, just from the police to Cindy, there was some
Yeah,
labels.
they used to go directly to Cindy, the police report.
Okay, and Cindy, were they given to you with any parameters in terms of these are the type of calls we want you to follow up on, or was it just kind of a blanket list and you were supposed to kind of decipher who needs a call?
So there was a certain criteria, right, where they would send it to us if there was already a second police encounter within a 12-month period. Then the victim's advocate would know that, you know, because of their process internally, and then they would actually send us the police report with the expectation that we would then follow up with that resident and provide whatever we needed to provide. So at that point, it was just, we were making a lot of cold calls where people just were not aware, and that's where everything kind of built up. But yeah, we've had numerous conversation of how do we, because that's the piece that I was like, we need that piece, because our program was, we were touching so many people. Because some people were, you know, okay with us reaching out, right? But it was just those couple individuals that's where it became a concern. But we were able to, you know, at least touch base with, you know, the follow-up that the victim's advocate couldn't do, right? Like we heard last week that they can't do that ongoing piece. So they're almost serving as case managers. So I think, you know, I think the last conversation we had with Indira and Ike was like, can we at least do a release of information where once they contact the person, because that's what they do as victims advocate, can they then get a release of information and a consent for them to have this type of program, right? But then it goes back to, are they willing to have this piece? You know, do they want this type of service? Some people don't most of the time, and they have the right to kind of say no. And that's the, you know, the part that I think a lot of the agencies struggle with, is that they have the right to pick, you know, to pick that if they wanted to follow through on something. So I think, yeah, it's something that if it's always been, and it's like, how do we go around this? So that's why right now it's been more of the consulting piece of it. Or it's been that because a lot of the city staff know the process, so they'll get the release and then they'll send me over the information. Or pre-COVID, I would actually go with the city staff to meet the individual and do that warm handoff. So do that introduction already. So we would meet at the Levy Center and get to know the person there on behalf of the city, because the city staff already had that relationship because they were working on something else with them. So right now we've been trying to do that piece of it until we figure out if it's possible where somehow we can coordinate the consent and the release.
Any other questions from the group?
I have a question related to that in terms of coming from a trauma recovery perspective, right? So I'm wondering at what point in the journey of a survivor that you're making contact, like if a victim's advocate's hand over, I don't know how the process is, but if you're given the information, right, and it's right away after an incident occurs, the willingness to accept care is going to be very different than a few months down the road, right? So I'm curious about that point. And then also in terms of the hotline that you offer, what is your definition of a survivor or victim of a crime who could have some sort of care, right? So does it have to be somebody who's directly impacted? Would it be available to friends or neighbors, for example, who witnessed the incident and need some support in trauma recovery? So curious about that as well.
Yeah, in terms of your first question, the timeline, I don't know how the victims advocate work in terms of how quickly the response is, like how quickly they respond to them, and then do they do a follow-up maybe on the second meeting they might offer this program. I'm not sure, I can't speak on that piece of it, but in terms of the crisis line, and I'll let Erica fill in once again, but I know that our crisis line is not a specific crisis, right? So people can call just for support. We have regular callers to our crisis line. Some of our clients here at the clinic call the crisis line just after hours, just to kind of have that support and be able to talk. But maybe Erica can fill in because she covers the crisis line, so she can kind of speak on, you know, some of the calls that she gets.
Oh, sure. Yes, we get all kinds of callers. We get family members who have questions about their loved one. We have friends. So everyone essentially calls pretty much. And so we field all kinds of questions and do mental health assessments over the phone if we can. If something seems severe, we'll encourage them to go to the ER, or sometimes we'll call 911 for them. So a lot depends on the situation.
And Evangeline, Indira's on the phone. Do you want to ask her that first part of your question? Or was it really specific just to Cindy's program?
Just to understand the connection, I'm familiar with the victims advocate approach, from 3 years ago, and I'm sure, Indira, that there's been changes since then, but just curious about, I know that the victims advocates continue to reach out, but we're also given a list of providers and none of them are in Evanston, right? So my willingness and ability to connect with a provider a month after a violent crime is going to be very different than my ability to do so 6 months later. Or, also the barrier of the distance of the providers that are suggested to us.
So we first would refer to Evanston therapists. The only time that we would refer outside of Evanston is if the family or the victim does not want an Evanston provider, because we do run into that sometimes. But as far as reaching out, we reach out as soon as we are notified that assistance is needed.
I think also, I know, Evangelina, just to, I know that sometimes it's treated differently for domestic violence. So we don't get directly though. So when we were even getting the reports, we were not getting specifically domestic violence because those would go to the YWCA because they specialize in domestic violence. So ours would be more of like the general mental health. So I'm not sure if that maybe plays a role in terms of where the referral is going.
That's correct. So the domestic violence victims will go to the YWCA, but we also don't share any type of reports with them either.
Correct.
Right, and so I'm thinking more about community violence, right? And the supports that we do not have in place for that. Because that's been my experience with my son's murder, right? Like there are friends, there are neighbors who have not had access to supports, and it's not readily known that there was a crisis line or that might be an option, right? Especially for people who are not insured or who are underinsured, to get some initial response to their need.
And I would agree. I mean, I think that, I guess part of that falls on the city as the contractor, which is, we need to let people know that there is a crisis line. I think we've done more in the pandemic because we've had so many crises. But even that, I mean, you have to look on our website and search through a couple of tabs and do a thing. And in the Evanston Care Network, I think, is a great idea and that it has everyone's stuff together. But I don't know that everyone knows about the Evanston Care Network. And then if you're home trying to search it, it is a bazillion different providers that come up.
And now
right?
they're also going to add it to, if it hasn't already done so, to the 311 prompt. So when people call 311, it'll be a prompt for them to get directed to the crisis line.
Right, which are all great improvements, right? But I think if we think of someone who is really in crisis, or we think about some of Marine's clients who are, right at the point of close to overdose, or, a variety of clients of really serious crisis who maybe are fearful or don't think that they need 911 or want to call an ambulance, going through whatever prompt is not helpful.
Mm-hmm.
And that's something we have to figure out as a city. So Chief Scott, I have a question for you in terms of the ECHO and Danielle, kind of the ECHO revisioning. So you mentioned this other model where you would have an ambulance and some kind of staff and they would be available kind of full-time to do this, delivery of services. I'm really interested in how you envision that working with behavioral health. So you mentioned a nurse practitioner. We've mostly talked about a mental health practitioner, whatever that looks like. And so thinking about some folks who James is encountering, right? So some of our chronic homeless who, need some assistance, but they don't necessarily need a paramedic, right? They need some other assistance. So how do you envision like the perfect ECHO model working if you had unlimited dollars?
Yeah, we're modeling our re-envision ECHO after something that's been really successful in Los Angeles called the Advanced Provider Response Units. So this is about 7 years ago, they started the program. They're up to 8 units now where they'll have, it started off really not focused on behavioral health, but as they got into practice over the years, they realized it was a major component of what they were dealing with. So they began expanding the training for their paramedics and for the PA to make sure they could handle those calls. So certainly if you look at the CAHOOTS model, their main primary focus is behavioral health, and they have a slight, kind of emphasis on medical with an ENTB. We look at it as we can expand our scope of care to include behavioral health and substance abuse and handle all those other things that ECHO was doing as well. And if we do it in partnership with AMITA, we can probably get some great financial support through the St. Francis Foundation, along with whatever the city can provide. So we might have actually an overall more robust program that could do more for the community, as well as address this behavioral health concern as well.
So would that model still go out and follow up with folks who were in the ER and be available to folks who are just, maybe haven't been in the ER at all, but need some behavioral health supports?
Well, I think ideally we'd want to make this something that would work out of 911, out of our emergency communication center. So it wouldn't be something where we'd get to them after the ER. We would have, like they do in Los Angeles, where the 911 call would come in and they would be directed to the advanced provider unit right off the bat, because the dispatcher can triage that and figure out, this is the appropriate unit to send for this particular call. And then they'd go from there. And then with the advent of telemedicine, I even envision this where you could imagine, even if it was a nurse practitioner or paramedic, where they could literally, through technology, get in experts and physicians and doctors to work with the patient, and again, deliver care exactly what they're looking for on scene versus having to transport them someplace. And then if we have to do follow-up, this is the integration part, we certainly could then direct them to different paraprofessionals and different social service areas too for continued follow-up, from that point.
And I think if I reflect back on some comments like Patty made, right, we talked about the 911 piece. So there are going to be some people who are just not comfortable calling 911, right? We know that that's where dispatch is happening now, but we kind of talk through, I don't know if that makes sense for everybody. And then if I think about some other clients and service providers, please jump in here, but if someone's having, whatever kind of episode, if we have a ambulance arriving with, several people with lots of equipment, does that heighten their situation or does that calm them, right? So if you all can kind of help me think through that, because it seems like another great piece. I don't know if it's the exact piece we're thinking through, but you all know much better as service providers.
Well, remember, I think in the advanced provider model, it's not like lights and sirens and they're screeching to a halt and kind of jumping out. This is not emergent. This is something where hopefully it would be a very, very calm, non-threatening environment where these medical professionals would kind of introduce themselves and integrate and begin care. So kind of keep that in mind too. And your point about 911, I think is well made. But I would say that the majority of folks, at least from my perspective, are still calling 911 when they're in more of that crisis moment. So I think on the fire department stats, we're getting about 750 plus behavioral-based calls per year that we feel we could probably handle in a better way, other than just transporting with the police and then going right to the ER.
Chief Scott,
Go
ahead, Kristen.
Thanks. For that advanced provider response unit, I may have missed it, so I apologize. Is there like a mental health professional as part of that team, or is it a nurse or somebody else who has that training? Do you know?
It's more the latter. So that the physician assistant, the nurse practitioner, paramedic are given training to get them up to that level. Just like in the CAHOOTS model, not all those people are certificated social workers or have advanced degrees in behavioral health, but they look at their experience, their skill set in kind of in aggregate, and then they make a decision to put them on the team. So I would leave the degree of training, I think, up to the professionals to figure out what would be the appropriate level of training, to be honest. But that's something I know that from the LA experience that their folks were willing to do to get that additional training, because they realized it was a lot of what they did.
So Chief Scott, you said that about 750 calls a year, 911 calls that get routed to the fire department are for behavioral crises. Is that?
That's
that
correct.
roughly what you said? Okay, so so is there, when the 911 dispatcher relays the information about this particular crisis call, can you tell already that it's a behavioral issue, or is that only something you find out once you actually get there?
A little bit of a mix of both. So sometimes it's going to be dispatched exactly as it's been expressed to the dispatcher that someone's having a behavioral health crisis, someone is looking for, there's an involuntary committal. So the other times it may be someone that's acting violent, for instance, and we don't know why. Paramedics arrive and realize that the reason for the behavior is some kind of mental health issue. So it can be both.
And so why does the 911 dispatcher decide to send it to fire department rather than the police department? Or sometimes they do one and sometimes they do the other, or?
Yeah, they do one or the other. So they do us, in a sense, an informal triage based upon their experience and training. Sometimes the police officer gets there first, tries to mitigate the situation and realizes, there's a medical issue here that I need to address too. Or if there's an involuntary committal situation, many times they'll call the paramedics so that the person can be restrained and then transported.
And then Cindy, so I know we've been getting sort of the 911 data sorted by different types of 911 calls. So for the calls that come to the crisis hotline, is there a way to sort of say X% are behavioral issues and X% are substance abuse, or is there a kind of categorizing that you can do about the kinds of calls that you get?
Erica, will you be able to answer that? I don't manage the crisis line, so I'm asking Erica. She's got our crisis manager couldn't join, so that's why she sent. So I'm not sure if Erica, you'll be able to answer that.
Right. Okay.
Yeah, I don't think we have a way to separate the calls, and so sometimes it's a combination of both, actually. But if it is like a risk of harm, we'll encourage them to either go to the hospital. We'll call 911 for them. And also, one thing I wanted to add from before is that if we sense that the person is extremely anxious, we're not sure how they would handle someone coming to the door, we'll sit on the line with them and just say, okay, once someone knocks on the door, answer the door. We will stay with them until help does arrive. So it's kind of like a warm handoff kind of thing.
I'm curious this is a question for Danielle and Cindy. I know you guys haven't had the volume in the ECHO program that you were hoping for yet, but I'm curious if you're seeing it having any impact on readmissions to the emergency room and the hospital.
So we actually, our ECHO program is currently on hold as we try to bring all the pieces together to find a new model that fits the city of Evanston as well as Amita best. We actually, COVID has changed the way our volume and our readmissions, so we really don't have solid data from the prior year to compare to, because we started this program in 2019 and then we abruptly ended the program in March of 2020. So I believe we started May of 2019 and then stopped in March of 2020. So we actually don't have a full year of data to show how did for the 42 the 14 residents that did accept into the program, did they have a readmission over the last year? And the ones that declined the program for whatever reason, what was their care like? So we have not started to capture that post ECHO 1.0 data yet to see how the program was, because we didn't have a full year. But I think that
we did track them for 30 days, Maureen, and out of those folks that Danielle referenced, we only had one readmission. So we thought that was encouraging.
Yeah, that's a really positive sign. And I can understand, you know, Danielle, when you lay out the timeline too, there's this big blip of about 4 months when people were avoiding the hospital at all costs, right? Because they were so afraid of COVID. And so that throws a wrench into this too. I mean, it does make sense that, you know, for the people who are the most frequent users of the hospital and emergency room, you know, and the fire department services, that this could make a really big difference. So it's promising.
And I think it also speaks to how we really should capture our patients before they come to the hospital, right? Because once they come to the emergency room, they now have a bill that's associated with that probably wasn't a necessary emergency room visit. So how can we capture them before that they are brought to the emergency room for a non-emergent visit? Just like Chief Scott said, if we could go to their home and have an advanced provider that can do an assessment and make a determination there, whether it is writing a prescription right there in the home or making a referral to an urgent care. That way we are taking the stress off of 911 as well as taking the stress off of our emergency department. So I definitely think that where we want to move with ECHO, we have a lot of opportunities. And what we found is that Evanston residents are not solely using St. Francis Hospital for their chronic conditions. So if we really want this program to be what it's designed to be, we actually may need to look at meeting patients in the community versus waiting until they show up at our doors.
And I was just going to chime in that I'm feeling really positive about what potential solutions we might have. Alderman Fleming, I feel like you brought a good mix in having us be educated on who's doing what. I feel like that some of the pieces that haven't been connected or maybe struggling to be connected, I feel like this group might be able to really do that. And I'm feeling pretty good about this now.
Great. Well, we have a few more, you know, information sessions, I'll say, to hear what else is there. You know, I think you're right. We'll kind of connect what we can. At least I think if nothing else, we'll have this new pilot that we'll watch and see what happens there. But I also feel like, and I just was looking on the high school's website because they sent out an email about the loss of life yesterday. And I realized even on their website, they don't have AMITA listed as a crisis line, right? So they have all these resources and they don't have the one here in town. And again, I'm not in crisis, thankfully, but even in looking through that, it's a ton of text, the different agencies, a lot of different phone numbers. And I just think if I have a 17-year-old trying to figure out who to call to speak about a friend I lost, that is just too overwhelming, right? So I think we can even maybe make some suggestions. And Cindy, I know you guys are doing some of this on the mental health task force. So I don't want to recreate the wheel, but
yeah, I think we are, but it's also, you know, I've even been hesitant to call it a crisis line because we do so much with that line. Like Erica's mentioned, like there's so much support that we do that's because I think most of the time because of the stigma around, right, mental health, where people, if they hear crisis, they're like, I'm not in crisis. I'm not going to call. I don't need to call that number. So I think it's also maybe the way we say it, like if you just need somebody to talk to, because that's also what our workers do. Like they provide that support, right? They can help you link to resources, just kind of be with you, do like a check-in, but then they also do the crisis piece, right? So like Erica said, if somebody's calling and then they need to navigate 911, the staff will do that and then they'll kind of stay with them. So I think it's just the way that we communicate that, right? And that's what our other group is, or the mental health task force. We're trying to normalize this. We're trying to like tell people it's okay to not be okay. Like we're all feeling overwhelmed right now with COVID. And even before COVID, we were all feeling these things. So it's okay to reach out to somebody and talk to them, right? So even when we did on our educational materials, we didn't put crisis. We put call our number, which is a 708-681-4357 for 24/7 support is what we put on there because we didn't want to put crisis. And then we have the 311, then we have saying call or text, then is the 311 number. And I don't have that memorized, but then it says for community resources. So we have kind of both of them side by side on the materials that we've developed, that only one material has gone out. So that's also something that our task force is working on. So it's just kind of our first flyer that went out, and then we're going to be sending out more information.
yeah. And I always want to be really mindful of our time. So do we have any more questions for our, Cindy, you're going to send us the PowerPoint so we can digest that. Great. And I made mention of this to Cindy, but I just came back to me and looking at the high school website, which was, you know, and Evangeline always reminds me of this just by her, who she is, but right, people are grieving a number of things during this pandemic, and then we haven't been able to come together and and support each other, and people are grieving from way before the pandemic. So just Cindy, your piece about the women's line, I think Alderman Ravel and I, we should really push for some kind of community grieving support, telemedicine, something, right? There's just a lot of grief that people came into this with and will carry for years and years. People who have insurance, who don't have insurance, to, you know, whatever. And so thinking about, again, as a city, what we can do with some of our resources and meeting people's needs to have that. So
there's a lot of community trauma, I mean, in the Black and brown communities that we still have to fill that gap of it, you know, so it's not COVID resources, it's not mental, like it's literally healing the community.
There's a ton of things, right? There's a ton of things, but this has been a summer where we have lost, I think, 7 or 8 young people, which is a ton for our size community. And then people have not been able to come together and support each other because of COVID. So I mean, it's just, I feel like we're going to come out of this all in a bad place if we don't really do all we can during this time to work with each other. All right, that's my little preach for the day. All right, so we will get Cindy, I'll get your resources. We'll get them up on our page. We might revisit you for more questions. And then Danielle and Chief Scott, as you guys are still revamping, Echo, if you would just kind of keep us abreast of what that looks like. And Chief Scott, you mentioned an LA program that I was not able to write down fast enough. So if there's a link or something you can share with me later, I can get it to the group as well so we can have a better idea of what your goal is.
I'll be happy to do that.
Thank you. All right, so we'll meet next week, same time. Next week we'll have the youth and young adult services folks with us. And then after that, I think it might be the holiday or maybe not. I have no idea. My dog is whimpering. You think that he has not eaten in years. So we won't convene for that 1 week of the holiday, and then I'll add on. What did I say I was adding on, Alderman Ravel? I talk so fast I can't remember. I was adding on some piece to our group here. What was it, people?
I think trying to get clients or people, who have actually experienced it, not necessarily a service provider, to speak on their experience.
Thank you. I had a great idea that I forgot, so thank you. So I will add that. I put in the chat the link if you want to come to that, or you can email me later. I can send it to you again. I don't know how great it's been. I think it will be great, but you know, we'll take a chance and see. But I would love for you guys to participate and hear, at least with the Ninth Ward, things about safety, so we can, you know, get as many voices as possible. And then I think that's it for the day, unless you all have something else you'd like to add. It's raining. All right, so I will see you all next week.
Okay, thanks.
Thank you. Thank you all so much.
Thank you for having us.
All right, thank you.
Bye.